You're going to phlebotomize for 50 more years every 2 months or 3 months. We're concerned that it's going to burn your bone marrow out. It's great for phlebotomy for people in the community to give some blood, but every month, every 2 months, you got to question that from your healthcare provider. You have to question that and look at your iron studies and how are you feeling? And are you exhausted? Are you depleted of iron? Again, let's look at telmisartan. We could limit phlebotomy because we're using this medication right here. Testosterone plus telmisartan, an old school blood pressure medicine that is one of my favorites to protect your health, your brain health, your heart health, kidney health, sexual health, and also for muscles. We're going to see that today.
I'm Dr. Thomas O'Connor, a lifelong powerlifter, board-certified physician, and published academic author. I've taken care of thousands of men on testosterone and steroids, and now I use my media appearances in this YouTube channel to provide education and harm reduction. Subscribe now so I can help you stay strong and healthy.
This is esoteric information regarding the androgen-induced erythrocytotic properties, and a lot of this is anecdotal that I've seen from my patients and myself over years and years, but I put it together for you guys in a presentation with a lot of evidence, and I want to explain that today. But first, let's go into what's going on. So just after the New Year's, or this actually might be January 1st, depending on when my guys get this up, of 2025, and I want everyone to be strong and healthy for as long as we can, and that's why I made Testosteronology and all my efforts and media and everything I'm doing. So thank you guys so much for always being in the zone here with me and listening to my information and my spiel. So testosterone is awesome, not to mention for women and men. It's out there now. It definitely builds muscle. There's no question for most every man and women. I don't care if you're young, middle-aged, or older, it's going to put on a little bit of muscle, and it's so important for people to be functional as they get older, right? So I'm repurposing a lot of this stuff to maintain functional capacity for not bodybuilders or steroid users really anymore, just for people to understand you could stay at home and you could be functional and strong. Remember the grandmother and grandfather home and they can't take care of themselves? Well, if you're stronger and you could function at home, grab the peas, make the food, do your laundry, man, you could stay home. And that's what it's all about, right? Being functional as I get older and older and showing you guys different PEDs and things you could use. So this is testosterone. However, we have to keep it sustainable. Of course, the effects, positive effects with so much data now for mood and sex and confidence, right? This is not bodybuilders. This is just guys and women even that are middle age or postmenopausal. Obviously, they're on a little testosterone for their quality of life and they want to keep the party going. We have to understand the effects on the cardiovascular, not to mention the other systems that we have, the renal system, the neuroprotective systems. When you understand that you have more and more people that are on testosterone, we have to understand your vital signs and your sustainability. And that's why I created the ABCDs on Testosteronology. It's a personal assessment, preventive health tool for you to utilize yourselves. Today, we're going to talk about the B in the blood pressure and one particular agent called telmisartan that I've been utilizing for decades with myself and my patients, of course, men on androgens because of the properties of it. Not just that it's well tolerated, but the properties of this medication. And I'm going to dive into that for you guys today in detail. When it comes to blood pressure, you really want to know your 24/7 blood pressure readings. That's why the data now shows that if you can take your blood pressure at home, In the morning, empty your bowels, relax, get the blood pressures, both arms. I've done videos on this. You can see my Instagram. I put up my own blood pressure there at least once a week or so, showing you guys that I'm always under 120 or right at 120 and under 120 and under 80. And that's optimal blood pressure. Don't let people fool you. And your doctor or nurse practitioner may not be aware of the new guidelines. You could just research that. You want perfect blood pressure. I'm 60, I'm on testosterone. Yes, I add some other agents occasionally, and you guys know that. I'm always looking to be strong and kill it. My brain is important, my heart, my kidney health. All together, it's synergistic. You can't tease any of this stuff out. Blood pressure is going to be key. Why would you live with blood pressure on anything but optimal? I don't understand it. And you have to understand, if you go to a doctor's office and you have either white coat hypertension, they're going to say, hey, get it at home then. What is it at home? Get the right monitor, check the blood pressures on both sides. It's got to be equal to or less than 10%. If it's not, you got to check out into that with a healthcare provider for why it's not. It's a whole other topic that I could dive into that I won't. And you need to check accurate data that's reproducible by good technology. And if you're in the doctor's office, it's more rare, called masked hypertension, where you're fine in the doctor's office, but you're not fine elsewhere, typically at home, where you can do 24-hour ambulatory blood pressure monitoring. It's much more complex and academic, but some of you guys may want to look at ambulatory blood pressure monitoring. I have found, and with the data, the experts in hypertension that are internists like me are going to agree, what's your blood pressure at home with a very good cuff that's systemic, you understand it, it's the morning, it's afternoon and night, what's the log looking like, is it regular, what are your activities, how's your diet, your salt intake, again, your Mediterranean, your steak intake, your everything. It's up to you. There's never one diet now. The DASH diet is best, but it doesn't fit for everyone. And even I've had my arm twisted on that from all of you experts and gurus out there that are very, very smart. There's never going to be one diet to fit all. But after your diet, here we are in the New Year's, right? After you're cleaning up your world, your diet, your behavior, you're doing the best you can with cardio, getting those 150 minutes in per week, wherever that came from, and understanding what is your blood pressure. After your behavior change, your diet, your exercise, meditation, everything, why wouldn't you utilize some biohacking, if you will, and do it properly? That's what I'm trying to get out and convince you guys of. I'm not selling you anything. I want you to do it yourself. That's why I'm providing you these tools in this evidence-based approach for you. You lose weight, you've done everything you can, your blood pressure is still high 120s, mid, upper 80s, or worse, that's the systole and diastole, you need to do something about it. It's biohacking, it's pharma hacking. Forget about the damn, you're not breaking down, you're protecting yourself. If you enjoy me and you appreciate me, you should listen to this behavior and these techniques and just see it as the kitchen sink. Anything you can do to maintain your quality of health. Okay, quick pause here for a second. I want to point out that I've opened another YouTube channel called Testosteronology. Over there, we're going to have a lot of content regarding just testosteronology, the Testosteronology app, the testosteronologists that I'm training all over the world for you guys, both for men and women that are on androgens and want to stay strong and healthy. Thank you so much. Now I'm going to talk about telimisartan. We're going to do a deep dive into this incredible medication here, but know that it's not just, don't copy me, guys. There's many antihypertensive medications. Let's review them first. Fortunately, it's quite simple. There's the ACE and ARB class, which is, this one is an angiotensin receptor blocking drug. This is what it is. This is the one we're going to focus on. It is If you talk to the experts in hypertension that are internal medicine doctors like myself, not just cardiology doctors, it's internal medicine, endocrinology, hypertension. Those are the nephrology. This is the organs. It's really nephrology, if anything, less endocrinology. It's nephrology, less cardiology. It's the kidney. It's that autonomic nervous system. It's internal medicine. So when you look at the ACE and ARB, it's the most classically utilized of all the agents we have. Next is, I will call them the most common, is the calcium channel. There's two types. There's dihydropyridine, amlodipine, otherwise known as Norvasc, and there's multiple non-dihydropyridine, diltiazem, also another classic dihydropyridine, nifedipine. I'm just giving examples. Thiazide diuretics, again, don't damn any of these. It's your fingerprint, and you need an expert to put it together for you that's experienced in hypertension management and understanding internal medicine. Thiazides, hydrochlorothiazide, chlorothalidone. There's another one or two out there. There's beta blockers. I don't like the beta blockers, except I don't like when people use atenolol, metoprolol that are non-selective non-cardio-selective beta blockers, because they just throw you a beta blocker. It's wrong to do. It's been wrong out of the guidelines for hypertension for at least a decade or so, maybe more. And I could tell you but Nebivolol, which we're not going to talk about today, it's an add-on synergy, and everything is synergy now. You start with one medicine, you go up to a certain point, and then you add on another one for synergy. We don't ramp up everything to 100% and start adding on meds. That's going to be new to you guys. For all your healthcare providers, you're in the know, you're academic like me, you're reading all the up-to-date information 24/7. You can't get enough of it, especially when it's all focused like this, like hypertension is. It's just, you have to understand synergy. But for this, Nebivolol is a cardioselective nitric oxide selective beta blocker. You guys know I like that together with telmisartan, but just don't do it if you're starting with one and you're new at this. Certainly, if I can get you young in your 20s and 30s, but not just blocking the effects of the steroids, you're on TRT. My God, that's funny. You're in your late 20s, but it's reality now. More like the 30s or 40s. You're doing the best you can, but you're not on proper medications as the kitchen sink to maintain your health, to have perfect blood pressure by hook or by crook. Next, we have alpha blockers like doxazosin. Then we have central acting agents. This is for my surgeons out there. I know plastic surgeons like clonidine because it just works really quick. It's right there, and they just can give it literally like in the office. I mean, they just don't want the plastic surgery of the face to be hypertensive. It's really interesting stories. This is fascinating. Vasodilators like hydralazine, and now we have minoxidil, right, for the hair, but it's also, if you do your deep dive, you'll see it's a vasodilating, direct vasodilator, and it's there too. Whoa, that's all your meds right there. Again, this is just for the academic guys here. So we're going to go and focus on telmisartan. It's a antagonistic of angiotensin 2. It's a type 1 receptor of those two blocker. It also activates this PPAR gamma and AMP-K pathway, peroxisome proliferator activated receptor gamma, and adenosine monophosphate AMP activated protein kinase pathways. That's all for you gurus, because I know you guys like this stuff. You focus on, and it's important. Because of those activation pathways, now I'm selling you why telmisartan is one of the most powerful and effective classes of hypertensive medications, and why it's going to be so good for guys that are on testosterone. Pay attention. It improves skeletal muscle function. It upregulates the myocytes and these myotubules and brings increased blood flow. This is through all the data that we're showing right here. There's so much data on this, and again, when you see the esoteric stuff, I've deep dived into some of the esoteric for you guys. Cardiorenal protection, nothing new, But it is, and it's great for that. And in the end of the day, my health and my ABCDs come down to the A1C, the glycemic toxicities are going to be so important. The blood pressure, here we are, the cardiac, the cardiorenal, the metabolic renal. You have to understand, you can't tease any of the stuff out from itself. And when you look across the board of telmisartan, cardiorenal protective, and improvements in cardiovascular disease, from heart failure to coronary artery disease, with or without renal disease. How many people, you guys out there, have coronary artery disease? And it's quiet. It's just quiet, and you need the imaging, and we're going to get more into that on the app, and you guys come to the meetings. Do you have imaging? We're getting away from the standard protocols to more imaging anatomical protocols of seeing what's in there and doing something about it based on you and your fingerprints. This is technology for today. I want to be the doctor to bring it to you. And next, we continue on this improvement of these pathways with the PPAR gamma and the AMPK pathways and other pathways. We have improvements, as I said, cardiorenal. There are improvements in endothelial function apart from the cardiac and the renal systems that are babies inherently together. We have systemic effects with neuroprotection in the central nervous system, improved lipid metabolism and lipid outcomes. It's all here, guys. There's reams of data for this telmisartan. And it's not that some of the other agents don't have some of this, but when you look at this and the sustainability and then in the effect on the red blood cells, which I'm going to show you, is just absolute incredible moons lining up for men on testosterone that have issues with the red blood cells. This is why you pick this one if you can. Next, improved pancreatic islet cell blood flow. The islets of Langerhorn, those B cells where your insulin comes from, insulin sensitivity, impaired fasting glucose problems, protections from glycemic toxicities, pre-diabetes, diabetes. Do you understand me? This is a medication that limits that. We have a lot of protection. We have a lot of data that shows this protection. And then also it has implications across many mammalian data research with lab rats and other animals. We have anti-inflammatory properties. Okay, now we all know this. What else do we see? There is this increase in adopinectin in the secretion that also will protect against the toxicities of glycemic destruction. And we also have anti-cancer effects. And also when you deep dive, you'll see there's anti-anxiety effects, again, in the central nervous system. So that's just telmisartan itself. Now, stand through this. We go into the deep dive why that's great to control blood pressure, and it's very well tolerated. And you have to, I'm going to talk about the doses in the end and some of my techniques how I prescribe to my own patients. And then when you look at the esoteric aspect on my ABCDs, you have that D stands for iron deposition disease, which is a condition called androgen-induced erythrocytosis, which is where doctors, even good doctors, they don't really understand it because they don't understand the steroids, the androgens that we've looked at for decades, and I've put it together, and I can tell you this is a deep dive. Let's talk about this D, which stands for iron potential deposition disease, which most men don't have it, but it fits in the acronym ABCD, the iron deposition disease. It's the androgen-induced erythrocytotic. You could watch my video here called Thick Blood, and you could see just a deep dive in that itself. But here's how it works, and here's how this telmisartan is going to interplay with this from science. We know that the androgen-induced erythrocytotic side occurs with a multifaceted mechanism of action. We don't understand fully what point in the line where your RBCs, your hemoglobin, hematocrit, not to mention iron levels are dangerous, but we know at some point it can be dangerous, where it increases the RBC count, the hemoglobin, hematocrit. It's called erythropoiesis. We know that. And how does that work? It works because testosterone, this is where there's no arguments, increases erythropoietin. It also affects the stem cell progenitor cells directly. Again, multifactorial, guys. It's more synergy. There's also something called hypoxic drive, that if you have sleep apnea, you're sleeping on the mountain every night and you're not oxygenating well, even a little bit, and you're getting older, age, independent risk factor for this condition of producing red blood cells, you're going to have effects of increasing testosterone, its effects on the red blood cells. Now, do you realize that of all the side effects of giving testosterone, this condition where the red blood cells go up, which is called androgen-induced erythrocytosis, is the #1 most common side effect. It's going to happen to women too. Now, is it dangerous or not? That's a whole question for you. And that's why I'm working on the app with you guys, for all this incredible data and to understand it man per man, woman for woman, and to understand what to do about it. Are you at risk? This is where doctors are globalizing, and we're healthcare practitioners, we're science guys, we're supposed to use science. This is where there's no end ABCDs directly. There's no data directly linking outcomes in this. It's secondary data, and it's not that it's not damn important, but you don't see. We look at this condition, and you're guaranteed to have a stroke, a venous thromboembolism, which is a DVT or a pulmonary embolism, or a blindness, or hypertension, or increase in coagulability that leads to a arterial clot in a stroke or a heart attack. I'm telling you, there's no data directly linking it directly. I initially was misled myself as a physician, thinking that it was, when I deep dove into this years and years ago with a lot of experts and doctors like you over in Europe. Thank you so much for contacting me on this and working it through with me. Hematology, nephrology, cardiothoracic surgeons, cardiology doctors, internal medicine experts in the world, and we've really looked at this. We know that it's not simple. What is your risk? I always say up to or less than, not equal to or less than 18 grams per deciliter. In Europe, you can do the math, move the decimal point, 52, 54%. But if you have symptoms, if you have blurry vision or headaches, or you're having some condition where this erythrocytotic secondary condition from the androgens and all the things that you're made up of are leading to problems, you have to decide what to do. And that's where there's the secondary effects. And then for my D, so the first effects are the hypercoagulable state with the viscous, if you will, just using terminologies that are not scientific, for the viscosity or that concentration with the hematocrit and the hemoglobin and the RBC. In whatever bed you're talking about, the CNS bed, the ocular bed, the cardiac bed, the venous bed, and outcome studies, which there are none. The next thing is, are you going to be at risk for two things? Too much red blood cell metabolism, with iron metabolism, apart from red blood cell metabolism, because it's a whole nother animal. But you have to see it as a unified synergistic mechanism of action. So this is where most men that are on androgens, they're going to have this increase in erythropoietin, depending on your genes and everything else I talked about before, hypoxic drive and sleep apnea, the amount of steroids you're on, your genetics. And then we see a decrease in hepcidin. Hepcidin is an iron regulating peptide that leads to iron utilization and is inherently related to androgen-induced erythrocytosis. And the downstream effects are you holding on to too much iron? When you look at those iron panels on my lab panels inside the app, outside the app, you don't need to be subscribed to this. You could look at on androgens monitoring or not, with or without testosterone, to look at your CBC with your iron studies. You can't just look at the CBC. It's not enough information. You need to look at the ferritin and the saturation, this transferrin saturation. This is the iron metabolism. And then I make my decisions patient per patient, looking at both knowing my guys and knowing their history way back. Because when you take androgens, you're going to see there's going to be, as I said, increased stimulation with the erythropoietin. We have it all laid out. The studies have proven it. We have the effects directly on the stem cells, hypoxic drive, and we have mostly this drive with an inhibition of hepcidin, not to mention diet. And in the end, with this, in the studies that we've seen, there's a recalibration of the erythropoietin set point with this inhibition of hepcidin. That's where you are in this condition where you'll see men that have H&H, the hemoglobin hematocrit is running strong, and then you're phlebotomizing, you're taking it off. And then when you look at that picture, it's dynamic. Because remember, the red blood cell itself lasts for about 4 months, and it's taken out of the circulation, depending on who you are. If you're healthy, if what's going on with your bone marrow, are you sick? Are you older? Have you had cancer? There's so many variables. Internal medicine is the base, the underlying motive here to understand this. You look at this snapshot, but most men have low ferritin, even though they're not dumping blood. Now, you start dumping blood, you're increasing the erythrocytosis, you're producing it faster. It's because this secondary recalibration, there's the paper, of the erythropoietin set point, because it's happening from androgen, and then you're taking off the red blood cells just to look at that number, just trying to keep my number down, mom, just trying to keep my hemoglobin at 16 or 15, they said. Wrong. Wrong for just using pieces of paper. Who are you? What's your background? That's what I want to know. And what is your risk? What's your risk assessment for hypercoagulable state? Do you understand this? And that this situation now is not complicated. You're because of this compilation of synergy of constantly stimulating the erythropoietin from androgens on top of all the other hypoxic drives in your genes. You're reducing hepcidin. You've recalibrated the EPO set point. And I see it. And then, are you living where it's sustainable to just phlebotomize over and over and over and over and over and over and over? Run that for 30 years. Run that, as irritating as it is. I want to limit phlebotomizing. On me, I haven't phlebotomized in years, and telimisartan is one of the reasons why. Because I'm getting older, right? So it should get worse. Independent risk factor of androgen-induced erythrocytosis is age. Just getting older, it gets worse, Mom. But not with me. As I'm getting older, it's been perfect. And I'm certainly not that skinny. I like to be skinny, but I do the best I can. But this is something that you have to understand for yourself. So how do you limit phlebotomizing and let your ferritin and, more importantly, your iron saturation stay normal? Are you depleted of iron? Are you just phlebotomizing and trying to keep your hemoglobin hematocrit normal? And are you tanked? Are you low on iron and ferritin? Which ferritin's a storage form, an acute phase reactant, and it's not always so accurate. But if you have multiple checks where you see your ferritin is tanked and your iron levels are tanked, and you're running with too much, potentially trying to keep your hemoglobin hematocrit down on androgens, testosterone most commonly, not to mention DECA and other great drugs that you want to maybe use for your shoulder, but you're limited because of this process of androgen-induced erythrocytosis. And now you're running with all the red blood cells in the wrong direction. You're phlebotomizing, taking off the top, and you're tanked and you're tired and fatigued because you have low iron status, and it's right there on paper for you. CBC, hemoglobin hematocrit, RBCs, and your ferritin and your iron studies. Your doctor doesn't know this, you need to do it yourself. And that's where you come and you work with me and everyone else on the app. Because you have to understand, my question is it sustainable? Great hematologists that know hematology, but they don't know steroids like me. They've said to me, Tom, I wonder, all your guys you're phlebotomizing, you're talking 10, 20 years ago now. We're just I was like all the TRT clinics too in the beginning. Like, hey, I use anti-estrogens. Of course, we use all this stuff. That's what everyone does. I don't know. He does it. Why don't everyone does it? That's why I started questioning things. And when I questioned this, I thought a doctor, a very good doctor, said to me, Tom, I wonder if all that phlebotomizing, first of all, we don't even know the danger zones with the hemoglobin hematocrit levels with guys who have no phlebotomizing. It's not polycythemia vera. It's an apple versus an orange, but obviously it's very complicated and we don't want to hurt people, so be careful. But can you phlebotomize someone for 20, 30? Hey, you're a 35-year-old guy, you're a 40-year-old guy. If you just live to the average age today, say it stays the same, it should go up. For some of us, it's going to go up because we're using technology. So we're going to live to 90 or 100. You're going to phlebotomize for 50 more years every 2 months or 3 months. We're concerned that it's going to burn your bone marrow out. Your bone marrow's doing a lot of work to replace all those red blood cells. I just explained that to you. Here's what I think. If you could use any kitchen sink to stabilize your H&H, I say H&H, hemoglobin hematocrit and iron studies, your D. You understand this now? If you could stabilize that, what is more important? To back off who the hell wants to, it's great for phlebotomy for people in the community to give some blood, but every month, every 2 months, you got to question that from your healthcare provider. You have to question that and look at your iron studies and how are you feeling? And are you exhausted? Are you depleted of iron? Again, let's look at telmisartan. Now let's look at telmisartan because I have so much anecdotal data. It's anecdotal, but I have a lot, guys. 20 years and over 10,000 patients now, well over 10,000. But I have reams of thousands of patients in my clinical charts that I've seen when they use a certain amount of telmisartan, in addition to the behaviors that we know to keep the weight down, don't use too much steroids together, not to mention everything else, who the genetics of the guy. We could limit phlebotomy because we're using this medication right here. So when we go into that, let's look at the data. Here we go. There really isn't too much data, but I'm going to deep dive on this +1 2015 non-diabetic hypertensive patients. You see that? They saw a decrease in hemoglobin and a reduction of erythropoietin with telmisartan. Now, they're not on testosterone, but think about this, guys. This is why I did this video for you guys. If you could limit the erythropoietin stimulation or just limit EPO in this erythropoietin-driven system of AIE, androgen-induced erythrocytosis, we know that recalibration will reshift back over and you're not going to need so much phlebotomizing, or in my case, no phlebotomizing in years. Now, the case was for olmesartan. It's not telmisartan, but you see why I like telmisartan. We assume a class effect, ARB for ARB. But we also have seen that there are effects of ACE inhibitors. ACE and ARB are very similar, that we see that on erythropoietin. Now, there is my data that we have in addition to all my anecdotal data. And I know some of you have enjoyed telmisartan and seen some of this too. Give me more comments on that. Again, I really want to do a real randomized, double-blinded, placebo-controlled study on this one day. And that day is going to come up soon, I think. Now, in full disclosure, I have one article that I found was very interesting, and it seemed to contradict this. This article is telmisartan alone or in combination with etanercept improves anemia associated with rheumatoid arthritis in rats. Now, when you look at this, telmisartan improved the anemia and arthritis parameters and showed anti-inflammatory and renal protective effects in rat models that have rheumatoid arthritis. Now, these are rats, okay, but it's interesting that what could happen, because there's so many vector forces with the devastation of inflammatory rheumatologic disease, that maybe the effects were so profound on the inflammatory, anti-inflammatory side that it had some improvement effect on producing, relieving the anemia. We don't know. We have no idea. But I could tell you the human studies with ACE and ARB shows that the side effects are something considered that need to be considered, and that are really something that are bad for people that are anemic. So I thought, wait a minute, it's for people that are anemic, that have kidney disease, end-stage kidney disease, or other types of anemia, you don't want to use this drug. And I thought, this is years ago, wow, but we're guys that have too much red blood cells, and we don't want to just be dumping the blood. I'd actually love to use some testosterone and decadirable, again, I'd love it for my joints and my quality of life, but I don't want to do it for one of the reasons, not to mention the cardiac fibrosis and all these other issues, but I don't want to see my red blood cells getting out of whack, and there I go again, dumping the blood and all this stuff. And my iron levels are perfect. You've seen my labs. My combination of my hemoglobin, hematocrit, and iron are perfect. And one of the big reasons is telmisartan. So hope you guys like the deep dive into this. Be very careful. Now let me conclude with telmisartan. You want to have a great healthcare provider. Doesn't have to be an internal medicine doctor. It's great if it is, but if you have a nurse practitioner, you could use one of our testosteronologists. We are getting more throughout the world. We have London now. We have South Africa. We have at least one, not to mention it appears like 2 or 3 coming in from Australia. And we have Chile, but we have all over America. So please feel free to utilize one of my testosteronologists. Now, the dose, if you use a little dose of this, I don't see it works. The dose is, for telmisartan, this is general information, be careful, this is general information, 20 to 80 milligrams. I like it's a QD drug, so the dosing guidelines say once a day. I don't like it that way. Most experts like myself will agree. We love to break it up, where we could use it every 12 hours and keep really more finger on the pulse. You can control the blood pressure better that way, especially when you use, if you look at it, I like most of mine at night, 2/3, maybe 2/3, 1/3. This is all fingerprint medicine, but I like to, again, use my telmisartan with synergistic drugs like nebivolol. I break it up every 12 hours, and I keep my blood pressure just spot on. Be careful. Now, the next piece is, again, with the synergy. We know that you don't take one blood pressure medicine anymore and just ramp it to the top. You start with one class and you increase it to a certain point, or you can even start with 2 or 3 medicines together. That's complex, and that's not for young people that are entering into treating non-optimal or very early levels of hypertension. Your diastolic blood pressure is 80, 82, you have level 1 hypertension. When you fact check that, you're going to go, wait a minute, this is crazy. Who wants to be 120/80? But is it worth it for you to start this on your own, like I've done, to protect myself and to deep dive into biohacking and pharma hacking? Because it's kitchen sink. That's up to you. How much risk do you want to take with your brain, your heart, your kidneys? That's up to you. That's why I'm hearing this word for you guys. Next, the combination of utilizing synergy for blood pressure medicines, not to mention glycemic medications and cardiac medications, is you get less side effects and better efficacy. Not to mention great pumps, great sex. And then when you understand utilizing it with PD5 inhibitors like telmisartan, it is just unbelievable for the CNS, for the IQ preservation, if you will, not to mention the heart and all these other aspects. Hope you guys really like the deep dive. A lot of comments. This is very technical. Be very careful. And if you don't have a good healthcare provider, come onto the Testosteronology app and consult one of my testosteronologists. Thank you so much, guys.